Neeraj, Ajay Majan sir will be joining.
Yes, sir. I'll just talk to him.
Okay. All right. We are live, sir. Good evening, Harishan sir. You can, sir, you're mute.
Hello. Good evening and welcome to the next edition of the Heart Failure Master. Initiate the Arun, you can start.
Yes, sir. So, good evening, everyone. So, the sixth episode of the Heart Failure Masterclass organized by the Heart Failure Association of India for 2026. So, today we have three sessions outlined. First is the talk on, much awaited talk on the second heart sound by Dr. Saurabh Gupta, professor from All India Institute, New Delhi. It will be followed by the case presentation from CGS Medical College and KM Hospital, Mumbai by Dr. Pooja. And the student panel is from JIP Pondicherry. And we have a lineup of eminent examiners who will take the case discussion forward. And this will be followed by the OSCE present by Dr. Dheeraj Kumar with exciting prizes in an interactive format. So, without wasting time, it's my pleasure to welcome Dr. Saurabh Gupta for his talk on the second heart sound. This is a much awaited session, and I hope the entire audience makes best use of the session by him. Over to Dr. Saurabh Gupta, sir.
Yeah, thank you, Arun. Thank you, everyone, for having me here. And it's my proud privilege to talk on Second Heart Sound in front of the eminent teachers. And I'm sure in the current era, we can't match the understanding of S2 which they have had in the past. But I'll try to make the topic somewhat interesting to everyone who have joined on Saturday evening. So the second heart sound to my mind is not just a sound; it's an auditory window into cardiac hemodynamics. So Arun, am I audible so that I go ahead?
Very well, sir.
Okay, fine. So to the participants, so there are two questions which I would like to start with. So if you can scan this barcode with your mobile, and then we'll have those two questions as polls. It will kind of make the session a bit interesting in the beginning, so that we have understanding why we are going to spend these 15 minutes or maybe 18 minutes on S2. So I hope people who are interested in doing so have already scanned the barcode. And I'll go to this poll. So you can answer and it will get reflected over here. Somehow this live thing keeps affecting people's response, but even then it's good. So I'm not able to see how many people have responded, but I think whatever is the number, it's good for us. There seems to be a bit of disconnect in understanding, and we'll see whether we can resolve it during the talk. Okay, for the interest of time, I'll move ahead to the next one. Again, I'm not sure how many people could participate. And in the interest of time, I'll move ahead and we'll try to see whether we get answers to these questions in the talk. So it's very simple to understand that we are talking about vigorous cycle, and this is the fundamental thing whenever we are talking about S2. So as the ventricle is going into the diastole after the closure of, after the ejection is over, there is pressure crossover. And well, closure happens, then there is incisura. This is what is incisura or the diacritic notch. And after that, there is the vibration in the blood pool, which leads to A2 and P2. So effectively, the sound A2 and P2 is either synchronous with the valve closure or it is slightly after that. And this has importance, and we will see how it comes later. Now, the basic question that we have to understand whenever we are analyzing S2 is, why does A2 precedes P2? And the answer, which will most often come to our mind, is hangout interval. And as you can see over in these two traces, left ventricular aorta and right ventricular pulmonary artery, as you can see, the crossover and then later incisura, there is a gap between the two. And this is called as hangout interval, which is 65 milliseconds on the right side and which is 10 milliseconds on the left side. So pulmonary hangout interval is 2 to 5 times of the aortic hangout interval. And that's why the most simplistic explanation of delayed P2 compared to A2 is hangout interval. Now, is hangout interval a ventricular thing or a great arterial? Is it a property of the great arterial system or the ventricle? Now look at it. The systemic ventricle circulation is higher resistance, lower compliance with brisk pressure decay, and it has hangout interval, which is shorter, and it results in A2, which is earlier. So primarily, the hangout interval is a property of the vascular system. And that is why whenever there is altered vascular property, as in case of systemic hypertension, it will lead to change in the A2. Or if it is PAS, then it will lead to change into P2 because the change in the vasculature has happened and that is leading into altered hangout interval. And this is the relative change in the hangout interval that would alter the S2 split in various conditions that we'll be seeing later on. Now, the next question is it only the hangout interval that determines S2 split? And I think by now you would have realized that it's not so. It's also because of ejection time. We'll see again with this diagram where we have already determined that the pulmonary hangout is more than the aortic hangout. So this is A2, this is P2, and this is the hangout. Now, if the right ventricle is under pressure overload, like in the situation of pulmonary stenosis, this is how it happens that the pulmonary incisura is further delayed. And then what happens to the A2P2 hangout is further wide, and that leads to further widening of P2. So there is increase in the hangout interval. Now, suppose there is aortic stenosis, then what happens? The A2 shifts to later, and that's how we have P2, which comes earlier than A2, and that is what we know as paradoxical split. So hangout interval is one, and second is ejection time, which will determine the timing of S2 split. Now, what determines the ejection in the left ventricle and the right ventricle is contractile function, ventricular afterload, alternate pathways of ventricular emptying, as in case of MR, TR, or VSD, or if there is conduction delay in activation like RBBB or left bundle branch block. And I think it's all obvious to people who are listening here. Now, is that all? Are there any other components which may be determining ejection in the left ventricle and the right ventricle? Now, this is ventricular interdependence. For those who are from MD level, I'll just make it very quick that during inspiration, there is increase in the thoracic venous return. Right atrium gets more blood, left atrium gets relatively less blood, and the same is affected into the right ventricle. Now, the right ventricle receives more blood, and hence the stroke volume of the right ventricle during inspiration is more than the stroke volume of the left ventricle. And therefore, in inspiration, there is early A2 and late P2, and that is what we know as ventricular interdependence. We may further call it as respirophasic ventricular interdependence. Now, this is what is physiological splitting. You can hear how it looks like. So this is pretty much what we expect. And as you can see, this is changing with inspiration, and that is why it is called as physiological splitting. Now, next question is, does only increase in the ventricular ejection time widens A2P2? The answer is that there are many factors. One of them is increase in the PA hangout, increase in the RV ejection time, and decrease in the QA2. So A2 becomes earlier. That contributes to almost 1/3 of this change. The PA hangout also changes. Now, this is something which doesn't come very intuitively. If there during inspiration, there is the reduction in intrathoracic pressure, there is pulmonary vasodilatation, and that leads to increase in the PA hangout interval. And therefore, that also contributes to the delayed P2 in these cases. Now, when do we hear a split S2? If the gap between A2 P2 is more than 30 milliseconds, and that is why during normal expiration, we will not hear it. Now, how should we listen to S2? So identify S1 and S2. Simultaneously palpate carotid or apex. Find A2. A2 is usually the louder sound. Then found P2. P2 is usually localized to the basis. And then assess the intensity of these two sounds relative to each other and in isolation as well. Assess the splitting and then do dynamic auscultation. Breathing, respiration is also a kind of dynamic auscultation, which will tell us which kind of condition we are dealing with. This is how we will analyze and assess. And I think this is summary of the same, the previous slide. It says the same thing, but we have to analyze in a stepwise manner. Now, what determines the intensity? So we have talked about the timing of S2, its component. Now we are talking about intensity. The intensity of the components will depend upon the flow across that valve, the mobility of that valve, the pressure in that great artery, vascular compliance or the impedance, and another important thing is transmission through the lungs and the chest wall. Whenever we are analyzing this loudness, we should be mindful of the thin chest wall of children and thick chest wall of elderly, because that can lead to altered appreciation of intensity, and we have to analyze or we have to discount according to what we are listening. Now, masking is another important aspect that we need to know, that whenever one component is louder or there is a murmur which is very close to the previous component, it may mask. Now, whenever we have such a situation of masking, we should unmask by listening at apex, lower sternal border, and away from the murmur. More often than not, we will be able to hear at a place that there are two components which are heard, and always rule out transmission problem before blaming physiology, because that if you label as abnormal, then it has interpretation issues. Now, as to splitting in health and disease, it can be affected by factors which will change QA2 or QP2 and the respiratory variation. We will come to these, what we hear later on, so I'm not going to the details. But suffice it to say that in young adults, we have to be mindful that there can be normal splitting during expiration, and that is a normal variant. So whenever we want to confirm that the expiration does not have splitting, we should make the patient sit or stand. And if you are hearing a split second sound in expiration, then only it is abnormal splitting during expiration, otherwise not. Similarly, in elderly, if we see due to changes in the pulmonary vasculature, the hangout interval keeps on changing. As you can see over here, this is 75 milliseconds. It reduces to say 25 milliseconds when the patient is older. And it has been found that up to 50% patients may have a single S2 in elderly. And that should be kept in mind whenever we are analyzing. Now, this is wide splitting of S2. Now, this is self-explanatory. If you see over here, then what is happening is during expiration, we are able to hear, but then it increases during inspiration. So there is variability based on respiration. And that is why it is also called as wide variable splitting of S2. Now, when this can happen, it can be because of delayed P2 in situation of right bundle branch block, RV failure, pulmonary stenosis, or ASD. It also can be because of early A2 in the situations like VSD, mitral regurgitation, myxoma, tamponade. The clinical question should not end at whether it is wide. We have to also answer whether it is wide variable or wide fixed. We will come to that fixity later. But when it is wide variable, we have to further ask ourselves whether it is late P2 or early A2 to be able to understand the underlying physiology. Now, these are various mechanisms and their examples of wide variable split. And for the sake of time, I'll just move ahead. And I think most of it is self-explanatory once we have thought about it. Now, these are the reasons which are because of early A2, severe AMR, VSD, and some certain situations like tamponade and pericardial constriction would also lead to early A2. Now, ASD is a unique situation where there is wide split, but without respiratory variation. How does that happen? So just see, during inspiration, the venous return from the systemic veins is increased. During expiration, since the pulmonary venous return is increased, that will fulfill this. So there is practically no difference, or there is marginal difference in the RV stroke volume during inspiration as compared to expiration. And since the flow across the pulmonary valve is nearly the same, rest of the things remaining same, the hangout interval remaining the same, the P2 remains equidistant from A2, and therefore there is wide fixed split in these patients. Now, ASD is also important to be understood because since RV becomes the apex, P2 may be heard at apex, and in this situation, presence of P2 at apex or lower down is not a marker of PAH. Now, this is what is fixed splitting of S2. As we can see, there is no change from inspiration to expiration, and that is why we call it as fixed. Now, S2 in PAH, high PA pressure will lead to loud P2. High PVR would lead to shorter hangout interval and narrow split or single S2. If there is RV dysfunction which is associated, it will prolong the ejection, it will delay the P2, and there will be wide split. Now, in VSD, depending upon what kind of VSD we are talking about, we will have different sorts of S2. And again, for the sake of time, I'm not going to the details, but the principle remains the same. As the PA pressure increases, as the PVR increases, the P2 comes closer. And if there is associated RV dysfunction, it becomes far away because the ejection has gone up. Now, this is paradoxical split. As the name itself suggests, it is opposite of what we were seeing in the physiological split. Here, during expiration, the P2 and A2 are louder. Actually, P2 is coming earlier than A2, and that is why it is called as paradoxical. Now, these are various mechanisms, and there are examples where you can see during LVOTO, since LV ejection has gone up, the A2 gets delayed later than P2, and therefore P2 comes earlier than A2, and that is the cause of paradoxical split in these cases. And I think if you think this way, either there is change in the hangout interval, or there is change in the ejection time, or there is change in the conduction system, that will change the split. Now, deep inspiratory S2 single is not always abnormal. We have to look at whether the patient has taken a deep breath. Always think that we have to do in a normal respiration. Always think of obesity, thick chest wall, and COPD whenever we are analyzing these cases. Now, S2 discussion cannot be complete without talking about cyanotic CHD. As you can see, the S2 changes in cyanotic CSD depending upon what is the location of aorta, whether aorta is dilated, what is the relative location of pulmonary valve, whether the pulmonary valve is abnormal, and based on it, you can see if the pulmonary atresia is there, or aortic atresia is there, or truncus arteriosus, there will be only one sound because there is only one semilunar valve. Now, similarly, if there is pulmonary stenosis in TOF, because of the thickened pulmonary valve, this SP2 is very soft and very delayed. We may not hear it. However, in cases of pink TOF, since the blood flow is good, the pulmonary valve is mobile, we may still hear a wide variable split, although the P2 is soft in these cases. And this is a summary of how different mechanisms will play out in different conditions of cyanotic CST. So what can S2 reveal? It reveals electrical activation. It also tells us about ventricular mechanics. It tells us about the great vessels hemodynamics and the vasculature. It talks about the well mechanics. And more importantly, it also gives us an idea about ventricular interdependence. Hence, to summarize, S2 is not merely a sound to be recognized. It is cardiovascular physiology made audible. Thank you so much for patient hearing.
Thank you, sir, for the fabulous talk. It was fabulous. Chopra, sir.
No, I think it brought back old memories. When we were doing medicine, this is all that we had. We didn't have echo, we didn't have all these fancy gadgets. So it was all first heart sound, second heart sound, third, fourth, and the interpretations. So I think it was wonderful. It just reminds you that clinical medicine still can yield so much of information, and also it can help you in deducing a lot of things, especially hemodynamics. Thanks a lot for this wonderful talk.
Thanks a lot, sir. And we'll go to the next part of our session today. It's my
Thank you.
privilege to thank you, Saurabh, sir. It's my privilege to call upon our examiners, Dr. Balachandra, sir, Dr. A. George Kochi, sir, Dr. Ajay Mahajan, and Dr. Santosh Satish to lead the case discussion. It's a short case, and I invite the case presenter from State GS Medical College in KA Mumbai, Dr. Pooja. You may please be ready with your slideshow. And from the student panel from JIPMA Pondicherry, Dr. Rajeshri, Dr. Hill, and Dr. Harsha, you may also please keep your video and microphone on and be ready to respond to the examiners. Over to the examiners.
Good evening, everyone.
Yeah.
Am I audible, sir? Yes.
Very well.
Okay, good evening, everyone. Today I'm doing a case presentation. So we had a 45 years old male, resident of Sambhajinagar, educated at 12th standard, farmer by occupation, came to us with chief complaint of dyspnea on exertion since 1 year, which was increased in last 2 weeks. Patient
The
was
slide is
apparent.
not
Can you
moving.
move the slides?
Can you
Your
move the
slides are
slide?
not moving.
Now,
No.
Not
No.
You
Vinay, you can
can
help.
stop share. Yeah, you can stop share and reshare. That's the best way.
yes, sir. Yes, sir. I'm doing. Is it visible now?
No, not yet.
So it's just starting.
Maybe it is coming up. No.
I think you can share again.
You can share your entire window. That will be the yes. Now it's
Is it
visible.
Now
visible,
it's
sir?
like,
Now
Can
we can
okay.
see.
okay, sir. Yeah. Thank you, sir. So we have a 45 years old male who came to us with chief complaint of dyspnea and exhaustion since 1 year, which was increased in last 2 weeks. Patient was apparently asymptomatic till 1 year ago when he started having dyspnea, difficulty in breathing. Difficulty in breathing was insidious in onset. Initially, he was able to feel breathless while performing his routine, while doing his activity like farming, but there was a relief of symptom on rest. Breathlessness progressed gradually over the duration of 1 year when he started becoming breathless while performing his routine activity and had to stop after walking a short distance. Patient visited nearby clinic for the same symptom 1 year back and he was found to have a decrease in a heartbeat and structural abnormality of heart. He was given oral medication over there which increased urine output, following which patient was symptomatically better and there was loss to follow. He was also advised to get a permanent pacemaker done. He came to KM hospital with the chief complaint of worsening breathlessness, currently in NYHA class 3. There's no history suggestive of orthopnea or PND. There's no history of pedal edema, abdominal distension. No history of chest pain, pre-syncope, syncope. There's no history of cough, expectoration, wheezing, and hemoptysis. There's no history of recurrent lower respiratory tract infection in past. There's no history of bluish discoloration of skin, nail, and mucous membrane and squatting episode. There's no history of decreased urine output, facial puffiness of frothy urine. There's no history of prolonged fever, hematuria, skin lesion, blackening of finger. No history of sore throat and flating joint pain. Family history, patient is third by birth order. There was no significant birth history. The personal history and past history was not significant. So coming to summary, it is 45 years old male who came with the chief complaint of increasing dyspnea and breathlessness since last 1 year, which has increased for last 2 weeks with the history suggestive of some structural abnormality of heart and decrease in a heartbeat currently in NYHA class 3. Should I move ahead, sir?
No, just wait. Uh, this is a short duration dyspnea in the patient who has uh, a slow heart rate. So if you interconnect both slow heart rate and dyspnea, decreased urine output, what would be your thoughts? We don't want full diagnosis, but at least the hemodynamics of a slow heart rate.
It is likely a cardiac breathlessness. It is likely a cardiac breathlessness which has resulted into the symptom and decrease in a heart rate. So it could be a congenital disease wherein there is a breathlessness along with decrease in a heartbeat.
Okay. So one of the causes is that he has possibly a congenital heart disease, and then that has resulted in the slow heart rate or a bradycardia and breathlessness subsequent to that, because otherwise, a patient who has complete heart block, will he have breathlessness? Who develops complete heart block, we've seen, who needs a pacemaker. Do they complain of breathlessness or they complain of course, they'll complain of Stokes
They'll
Adams or
complain of
syncope.
either syncope or syncope than breathlessness.
Why they don't have breathlessness when the heart rate is slow? Why there is no breathlessness? So the cause of the breathlessness is increased PVH, isn't it? Pulmonary venous hypertension is a likely cause. So will that slow heart rate result in PVH? If so, due to what? If there is a PVH, or if there is some valvular abnormality due to a slow heart rate.
So if there is some valvular abnormality which is
Yeah.
increasing pulmonary venous pressure, it will present with breathlessness.
Okay, so it can be due to a valve abnormality, mitral valve. It can be due to a mitral regurgitation, which can give rise to a cause. Okay, when does slow heart rate cause symptoms? Aortic regurgitation or mitral regurgitation? Which one will cause more symptoms? You see that aortic regurgitation, the patient has an inherent
Aortic
tachycardia.
regurgitation, sorry.
Why does he have tachycardia?
Aortic regurgitation patient will likely to have a more breathlessness with a decrease in a heart rate.
Is it? Because bradycardia will increase
It
aortic
will increase the
regurgitation, but it does not
regurgitation.
mean that the pulmonary venous hypertension will increase, isn't it?
Okay.
Okay, coming to this one side question, why do you not get increased pulmonary venous hypertension in a patient who has aortic regurgitation? It will not be related to the case, but it's just for discussion. Why, if you have mitral regurgitation and you have LV dysfunction, etc., you may have PVH, but in aortic regurgitation, the LA pressures don't go up, even though the LV-EDP may rise, isn't it? Why doesn't it go up in aortic regurgitation?
Because LV is compliant, it is compensating, and hence there is no much increase in a pressure on a LA side
It
in a
maybe I'm not.
compensated AR patient.
Yeah, that is true. That is the LV problem. The problem is why it is so is because the aortic regurgitation will lift the anterior mitral leaflet into a semi-closed position and prevent the pressures from getting transmitted from LV to LA.
Okay.
So this may be a cause of pulmonary venous hypertension occurs very late only when there is LV problems otherwise. Okay. All right. Dr. Koshi, you'd like to?
No, I think from the history, it is very evident that the patient has a slow heart rate. That is very, very clear. Patient has been advised a permanent pacemaker implantation and has been pointed out dyspnea on exertion is an important symptom of this patient. There's no PNB. So we will take it as a left heart symptom. So two things come to my mind. One, is it related to a valvular heart disease or is it related to a myocardial disease? Now, valvular heart disease, I am not considering a stenotic lesion. Now, regurgitant lesion between MR and aortic regurgitation. Those are the two things which Dr. Balchandra has discussed already. The second thing which comes to mind is a condition in which there is bradycardia with myocardial disease. That is the other possibility. I think these are the two broad ways of discussing that. And if you are considering a congenital heart disease, you should consider those in which there can be a slow heart rate and an AV valve regurgitation of the left side. So, corrected transposition of the great arteries or conditions like that should come top in the list. Now, if you are considering a myocardial disease, you should consider some form of cardiomyopathy
Yes.
in which there is associated reduction in the heart rate.
Yes.
One small point is it a complete heart block or a six sinus syndrome? Because basically, when you tell about slow heart rate, it will be either of the two. In general, people with complete heart block tend to be more symptomatic because the heart rate tend to be slower and they more often have syncope. But congenital heart block, complete heart block may remain asymptomatic for a very, very long time. Whereas six sinus syndrome, people tend to be less symptomatic other than some reduced effort tolerance and all those things. Those will be the two broad headings in which I would like to discuss.
So why do they advise a permanent pacemaker? What do you think would be the reason that a permanent pacemaker has been advised, even though there is no syncope? Of course, there is bradycardia, but
Then
why do you think that the patient was advised a permanent pacemaker?
it says likely patient is having some advanced heart block than the sick sinus syndrome or junctional bradycardia. So some disease which is resulting into severe bradycardia, which is like CHB or advanced AV block. Likely patient is having based on history, which is requiring permanent pacemaker.
Okay. Fine. So we will work on these two, which Dr. Koshi has pointed out, either myocardial or valvular problem. But at this point of time, can you give us a broad differential diagnosis on which you will base your clinical findings? What you
Yes, sir.
thought?
Considering congenital, the causes, congenital, I'll consider it to be a congenitally corrected transposition of great artery.
Okay,
Second, maybe AV canal defect, which is presenting with the rhythm disturbance. Third, for the myocardial disease, we can consider it to be a restrictive cardiomyopathy.
fine.
Congenital CHB, atrial septal defect, ostium secundum atrial septal defect with junctional bradycardia, restrictive cardiomyopathy, dilated cardiomyopathy, rarely heterotaxis syndrome. So
Can I
these are
ask a
the,
question?
yes,
Between
sir.
AV canal, between endocardial cushion defect and corrective transposition, which do you think is more likely to become symptomatic because of bradycardia at the age of 45?
Yeah,
Sir,
it's very relevant. We have to
AV
think
canal
of it
defect. AV canal defect will be more symptomatic.
No, AV canal defect will present earlier usually.
Yes, sir.
because both pH as well as MR will be there. So it is likely that the presentation may be earlier.
Early. Yes,
In
Okay,
yes.
corrective transposition, the left AV valve regurgitation tend to be progressive. And many of them have to begin with, 2 to 1 block, and later it can progress to higher grades of block. So if you think someone was totally asymptomatic till the age of 40 years,
Yes, sir.
and you have identified a structural heart disease with bradycardia, statistical possibility is it could be a corrective transposition.
Yes.
more likely, isn't it? What about this? Why did you think of this ostium secundum ASD with junctional bradycardia? Why it came to your mind?
So middle-aged male he's having increased dyspnea for last 1 year. He was asymptomatic till then. So late presentation of ostium secundum ASD, and since history told us that there's a decreased heart rate in a familial OSASD, when there's a junctional bradycardia, we can keep one differential.
And familial type of ASD. So
Yes.
what syndrome is associated with a familial ASD with junctional bradycardia? Any syndrome you know? Of course, it will not occur in 45 years. The patient
A
will present
Holt,
much
morphological
earlier.
abnormality.
Holt-Oram syndrome.
Yeah, very good. Holt-Oram syndrome. And things with that gene is called NKX 2.5, isn't it? That's the gene which is responsible. Okay, fine.
Dr. Pooja, one more question. In ASD with junctional bradycardia, why should there be left heart symptoms? Ostium secundum ASD?
There won't be, sir. They
Unless
won't,
Unless you
unless
think there is
associated with MR.
pulmonary hypertension contributing to dyspnea exertion,
Oh,
which is again not out of place in the discussion because this patient does not have any PND. If there is PND, then for 100% you can tell it's a left heart symptom. In the absence of PND, you should have a broader approach to dyspnea on exertion. It can be a manifestation of pulmonary hypertension as well.
okay.
fine.
Student panel, anything to add from?
You'd like to add anything?
No, sir.
As far as the differential diagnosis is concerned, in the order of it's already said that between AV canal and corrective transposition is a little more possible.
Now, one more
Anything
point.
else?
Among the cardiomyopathy, which do you think is the most likely if you are considering that?
So likely,
Between restrictive, dilated, and hypertrophic cardiomyopathy, which would you consider?
so likely restrictive cardiomyopathy presenting in the middle age group. I would like to think of sarcoidosis in this case, which has come with conduction abnormality.
I think that's an important
It is,
point.
it's
If
an
you are
important
considering
point.
RCM, you should consider that. Okay,
Sarcoidosis is one of the possibilities. You didn't
correct.
mention hypertrophic cardiomyopathy. It can also be a part of the differential diagnosis
Yes.
of this. But can complete heart block occur in HOCM? Conduction abnormalities in HOCM
They
are
come with atrial fibrillation, sir. but in burnt out HOCM, it may come as CHP.
Okay. It can occur. It can occur. Although, of course, there is pre-excitation, etc., can be there with HOCM, left-sided usually, but it can be there as a cause. Okay. We go to the examination to see.
Okay. Moving towards the examination, patient is conscious, cooperative, well-oriented to time, place, and person. He is averagely built and averagely nourished with a body mass index of 21.7 kg per meter square. His blood pressure in all four limb, it was 104/70 in right, 102/70 in the left upper limb, and bilateral lower limb blood pressure was 118/70. His pulse was 44 beats per minute, which is low, regular, normal volume, with no radial and radiofemoral delay. Peripheral pulses were felt equally with normal condition of a vessel wall. Saturation was 99% in all the four limb. Jugular venous pulse JVP is elevated. It is 7 centimeter above sternal angle in a semi-recumbent position. There are prominent cannon A waves present which were irregular. There's no dysmorphic feces, no skeletal abnormalities, no pallor, icterus, edema, cyanosis, and clubbing. So this is a video of a jugular venous pulse of the patient. Shows prominent A waves and intermittently irregular cannon A waves.
Okay, but for terminologically, we don't like to call them as A waves, isn't it? Why?
There's
Because
a A
cannon A
wave
waves occur during where? During ventricular
when
systole,
there's
isn't it?
atrial contraction against a closed
Close to
tricuspid
tricuspid
valve.
valve, isn't it? So for the A wave to occur, the tricuspid valve should be open. So strictly speaking, we should not call them as A waves. We can call them as cannon waves.
Cannon A waves.
Okay.
Moving towards inspection. Chest is bilaterally symmetrical. Transverse diameter is more than AP diameter. Trachea is centrally located. Apical impulse is diffuse. It is approximately seen in a 6th and 7th intercostal space lateral to mid-clavicular line with apex retracting medially. There is no evidence of precordial bulge, a scar, a sinus, visible pulsation and dilated vein with no use of accessory muscle. On palpation, inspectory findings were confirmed. Apex beat is palpated in 6th and 7th intercostal space. It is diffuse. It is hyperdynamic in character. It is located 12 centimeter from mid-sternal line and is associated with medial retraction. There is no evidence of palpable P2, parasternal heave, thrill, with no epigastric pulsation felt.
Can I interrupt you for a minute? See,
Yes.
in palpation, you should mention whether anything is palpable in the second or the third space because 1DD was a character transposition. So we would like to know whether there is something anterior which is palpable. You just told palpable P2. Palpable pulsation of the vessel and palpable P2 are different.
Yes.
Palpable P2 only tells that the pulmonary valve closure is palpable. Is there any pulsation
Pulsations.
which is palpable?
No, sir. No, sir.
It's a very important negative point.
Okay. On percussion, left heart border corresponds to apex, right border is substernal. Left second intercostal space is dull on percussion. Upper border of liver dullness is at right fifth intercostal space in a mid-clavicular line. On auscultation, S1 is soft.
So before
S2
we
is
go to auscultation, what do you expect from the other findings of JVP and Apex? Did you think of anything else before we go to auscultation?
yes, sir. Based on inspection and palpation finding, it is likely a RV type of apex.
Okay.
But when we checked epigastric pulsation, there is no pulsation, saying that there is likely L looping of a ventricle, because of which we are getting RV apex with no RV pulsation, and that is associated with CHB, which is confirmed by Canon A waves on JVP.
Dr. Pooja, can
Okay.
you have an assumption like that?
Can we
See, in
say
character
clinically like that?
sorry, please go ahead. Please go ahead, sir.
No, can we say that because the epigastric pulsations are not felt it's because of the L looping? Can we tell that there is RV, the whole precordium is RV, but you don't feel the epigastric pulsations? Can we say that clinically? I mean, is it possible?
See, in
So under
chemical
what,
transposition, it is morphologically a right ventricle, but it is facing the systemic pressure.
isn't it? Okay, fine, go ahead.
On auscultation, S1 is
So
soft,
we do
S2
expect on auscultation what? Before, to, okay, go for auscultation. We'll come back again.
we'll get there's a soft S1, there's a loud narrow split of S2. There's a grade 3 pansystolic murmur, high pitch blowing systolic murmur, best heard in the left sternal border, radiating to right sternal border, and epigastrium increasing with hand grip, decreases with standing.
Okay. Anything else? You have a loud S1 and normal
It's soft
S1,
S1, sir.
and
Any
you have a
variation in the intensity of S1?
S1
Because from your
because
presentation,
complete
we
heart
thought
block.
it's a complete heart block.
What happens
So
to S1 in complete heart block?
in complete heart block, S1 will be soft.
It will be soft
Soft.
or it will be variable.
Variable, sir. Yes,
What are the
It
variable.
has to be
factors which
variable.
decide the intensity of S1?
In the
Um,
same context, I'll ask you a question. In pre-excitation, what will be the S1?
so in pre-excitation, PR interval will be less and S1 will be loud.
Not necessarily, isn't it? Pre-excitation and the QRS is formed due to, how is it formed? It is a fusion, isn't it? Between what? The accessory pathway and the normal conduction, isn't it?
Normal. No, yes.
So it may not show any change. It may be normal. It need not be loud, especially if you have of course,
Accessory path.
short PR interval can have a loud, but because of this fusion, it may not
Okay, sir.
be that obvious.
There's
Okay,
no
this just
mechanical delay usually. So
okay.
S1
So
should be varying intensity.
fine. What about you got a pansystolic murmur? This is due to what actually? Of
There's
course,
this
today's topic is second heart sound. So what does the narrow split of the second heart sound tell you?
it is a left-sided AV wall regurgitation,
Okay.
like mitral regurgitation, which
But
is
that should
causing.
have a little wider split, isn't it? The A2 should close. But here it is narrow split.
Yes.
Dr. Pooja,
Okay.
that alone is not enough. You have to tell about the intensity of the sound, you know. When you tell about S2, you have to comment about P2 and A2. This is only part of the description. So we expect the S1 to be varying in intensity. Second heart sound, you tell it is narrowly split. So we would like to know whether P2 is normal, soft, or loud.
Sir, on auscultation, we appreciated that the P2 is loud. The second heart sound is loud.
Second heart sound is loud. Okay.
Not second heart sound, P2
P2.
or A2.
So in this case, since the left intercostal space was dull and there was no sign of a right-sided this thing, and since my one of a differential was CCTGA,
Hmm.
it is likely the aorta which is there.
No, no, you don't mix the two. See, we want your description about the second heart sound. It's not complete. You have told about the split of the second heart sound, but we would like to know the intensity
Intensity
of P2.
and where is it heard?
See, that was the discussion today. 50% of
Yes.
cardiac auscultation is centered around S2.
So on apex, The intensity of S2 is equals to that of
Not
S1.
S2, P2.
P2. Okay, sir. Which says that the second P2 is loud.
P2 is loud?
I said it is second heart sounds, sir.
No, Dr. Puja, you are not getting our point.
The
See,
point
second
is,
heart sound, you have A2 and P2.
See,
So what?
Puja, the
Yes, sir.
thing is that ki here aorta is anterior and pulmonary wall is posterior.
Yes, sir. Yes, sir.
Another thing is that ki there is any evidence of pulmonary arterial hypertension on clinical examination or any symptomatology on that you have to decide. But whatever you are hearing is A2 or P2. Sir is asking that question.
So that is A2, sir. What are we hearing in this is likely A2 because clinically there was no sign of a right-sided involvement or right pulmonary hypertension. So likely the sound which we are hearing is the aortic component of the second heart sound.
See, the point is when you tell it's a narrow split, still you are hearing two sounds, A2 and P2. If you are telling it a single second heart sound, then we will not ask that question. But whenever you tell the two components are audible, the next question will be what is the intensity of the sounds? So make that point. That's a very important point. Because a lot of things are based on that. Our further discussion. And you did not palpate any vessel in the second space, though you could make out some dullness.
so where is it best heard? This loud S2 or part of the split?
The part of split is best heard in a second intercostal space, left second intercostal space.
Okay. So how do you know if that loud sound is in the second left intercostal space, it is A2 or P2? We don't spend too much time on second, but today is a day of second heart sound. So that is why we are spending a little bit more time.
So after correlating with the rest of finding,
Mm.
it
So
No,
is
I
not.
think
always when you auscultate the second heart sound, you must start at the second right intercostal space. Even if you read the New Hurst, it says begin the auscultation itself with the second right intercostal space, not at the apex, standard. And then inch your way down the left sternal border to the apex. The sound which is heard up to the apex is usually A2, isn't it? P2 is rarely heard in the apex, except in case of pulmonary arterial hypertension or ASD. ASD, of course, you can hear without pulmonary arterial hypertension. So, and then you can come back again and see what you are dealing with. Loud S2, is it A2 or P2? The same will hold good for even paradoxical split, etc. All right.
Okay.
Coming to the murmur, what murmur is this?
So it was a pansystolic murmur, which was best heard in the left sternal border. It was a
Okay.
high-pitched blowing murmur. The murmur was radiating to the right sternal border and epigastrium, and it was
Okay.
increasing with hand grip and it was decreasing with standing.
So the murmur is
So it is likely a murmur of a left-sided AV wall
AV.
regurgitation.
All right. Can we get a diastolic murmur in complete heart block? I'm not talking about a corrected transposition, but can you hear a diastolic murmur in complete heart block? See, previously, I mean, because you don't read the older books, so it was called as right hand murmur. It was a mid diastolic murmur across the mitral valve in complete heart block. But of course, it has been taken off. I don't think it's relevant. But you can get a mid diastolic murmur in complete heart block. What about S4?
So S4 was not heard.
Not here.
what do you call that? The atrial sound you hear in complete heart block.
Complete.
Is it called as S4 or something else? Have you heard of semi-beat of Stokes? Because you have more atrial sounds than
Sound.
S1 and S2.
But they are not called S4, isn't it? Okay, fine. All right, we'll go forwards because
What about the third heart sound? Any MDM? Because ultimately you are telling it is an AB valve regurgitation. What will be the etiology? So the next question will be what is the severity of that AB valve regurgitation? Whether it is MR or corrected transposition. So important thing will be you tell about the third heart sound. Any decrescendo, mid-diastolic murmur indicative of a flow across the mitral valve.
left-sided valve.
And that's all the more important. This patient is in bradycardia, complete heart block. So there is every reason that there should be a mid-diastolic murmur. Are you hearing a mid-diastolic murmur?
So we couldn't appreciate the
Okay.
mid-diastolic.
Because you have given us an impression there is significant cardiac enlargement, meaning there has to be ventricular dilatation. So anything in diastole or diastole is totally silent.
We did not get any mid-diastolic murmur or S3 in this patient.
Fine. Shall we go
Why
to
is the murmur conducted medially to the right sternal border? Usually the MR murmurs are conducted to the axilla, no? Which are the MR murmurs which are conducted medially to the right sternal border?
So here in this patient, the left-sided valve is a tri-leaflet valve. So this tri-leaflet valve is likely to push that regurgitant jet
But we are not yet
posteriorly.
sure. See, we are yet not sure whether it is correct transposition or not. We have not reached that level. We are having a clinical discussion. The other one is after
so in which
investigation.
condition you can get this sort of a transmission? That's what the
Common
question.
condition. You tell the common condition where the murmur is conducted medially so that you may even think it's an LVOT murmur. Sometimes, classically the MR murmur is conducted to the axilla and back. Sometimes the MR murmur can be conducted medially towards the aortic root. When it may be difficult to differentiate it from an LVOT murmur, what are the two conditions where such a phenomenon happen?
So in HOCM,
Okay.
Classical one, mitral valve prolapse with prolapse of
Perhaps
which leaflet? Which one? AML or PML? PML, that's the point.
PML.
because
See,
that's
when you do
only
echo, you can see the jet going into the aortic root. Next time, when you do an echo of a PML prolapse, have a look at the direction of the MR jet.
fine.
Okay.
Okay, we'll go to ECG.
Yeah. So this is a standardized 12-lead
First,
ECG.
should we discuss the diagnosis, clinical diagnosis at this point, or we will go to
At
the
this point,
investigation
okay.
and then have the discussion?
I think it's better to have what do you think now with the clinical examination? That's better than going for ECG. What do you think with these findings of a murmur and a complete heart block?
So it is a case of situs solitus with
No, that is
leocardia.
after your investigation, we are asking you about the clinical
At the
diagnosis.
moment, what do we have? You have Canon waves, you have so like that,
Yes.
and you have a MR murmur.
So
Then you have
it
cardiomegaly.
is
So coming,
likely.
putting all that,
So you tell about the situation where there is a complete heart block, for sure, because complete heart block you can clinically make out because there is regular bradycardia, irregular Canon wave, varying intensity of first heart sound, and all those things you have made out. So
Yes.
complete heart block is for certain. And you have identified an AB valve regurgitant murmur which is conducted medially towards the aortic root. So considering that, you tell about one or two differential diagnoses. And then we will go to the investigation and find out whether it is a really correct transposition or something else.
Okay. So HOCM with CHB will come with this.
No, but the points you are telling are against HOCM. You are telling when the person is standing, the murmur is coming down in
coming
intensity.
down for the dynamic auscultation is against, isn't it?
Even without asking, you mentioned that.
A
Okay.
case of AV canal defect with the left AV valve regurgitation murmur.
Yeah, it's possible.
No, the endocardial cushion defect, what will be the usual description of the second heart sound?
Second heart sound is
So it will be loud.
No,
What will be the split of the second
split.
heart sound? What is an
Split is
endocardial cushion defect? What are the components?
So we have basically there is a failure of fusion of the endocardial cushion, and there's formation of a common AV valve,
No, no,
which
we are not asking about the embryology and all that. Clinically.
It's a hint, sir is asking. In endocardial cushion defect, what all is associated with it, which will create a classic second heart sound, feature.
feature.
Endocardial cushion defect, no?
yes, sir.
What are these?
See, this
Yeah,
is not a
What is it?
common AV canal. It will not present at the age of 45 years. If you are
yes,
considering
No, it will be
endocardial cushion
partial
defect,
only.
presenting at
Partial
the age of
AV.
45 years, it has to be what combination?
Ostium primum ASD with cleft AML, no? Or
Then
at the
what will
max,
be
you can have
the second heart sound?
any ASD with any ASD. What does it cause to the second heart sound? We just heard.
it is wide. Any SD will come with wide and fixed
Correct. You told
second
it's a
heart sound.
narrowness with second heart sound.
And one very important thing is in ASD, you can get a palpable P2. It does not mean pH. So you can get all those findings and you still do not commit to pH.
True.
I think we'll go to the investigation,
Yeah,
otherwise we'll
go to
get
the
delayed.
investigations. Fine.
Okay.
So this is a standardized 12-lead ECG, which shows AV dissociation with
We can
presence
involve the
of
student panel also, sir.
Sure. Okay, then before going to the investigations, what do they think it is? Anybody from the student panel? That she has told that there could be mitral regurgitation, it could be corrected transposition, it could be HOCM, it could be a partial AV, anything else it can be? Anything you'd like to add or say? Okay, we'll
Student
go to
panel.
the. What do you think? Based on the findings, you may right or wrong, it hardly matters, but whatever comes to your mind, you can tell. Okay, fine, we'll go to the ECG, no problem.
So this is a standardized 12-lead ECG, which shows AV dissociation with the ventricular heart rate of 55 beats per minute. There's presence of multiple VPCs.
Now, would you like to call it as a complete heart block?
Advanced AV blocks with multiple VPCs in it.
What is that? Is there any conducted beat? That's the question.
Nope, sir.
Hmm?
The JIPMA team, can you attempt reading the ECG?
There are some conducted beats which are seen.
Actually, we require a real long strip, otherwise, it's not very easy to
But
tell.
yes, there is
But from
possibility of
whatever is
conducted.
available, it seems there's no conducted beat. What do you think, Balchandra, sir?
I think it is, I don't can find any conducted beat, but what you
What are
still
those
want,
narrow complexes and
narrow
broad complexes?
complexes are there.
There are two types of complexes, narrow and broad.
So these narrow complexes, I am considering it to be an actual beat, and these are the VPCs, the wide
Okay.
complexes which
No,
are
No,
coming
if
in
you are
between.
considering the narrow complexes to be actual
then
beats,
it's
do you mean they are conducted beats? See, in complete heart block, you have escape beats.
So the escape is at a junctional level and escape at
yes.
a
Little
peripheral
lower
level,
level, yeah.
lower level. So you have to discuss in that way.
Because if you see, of course, you need a longer strip, but even lead to AVF and all, you don't get any conducted beat there.
Hmm.
Nothing is a capture.
The point is, if it's a complete heart block, there cannot be any conducted beat. So whatever you are seeing is escape beat. And narrow QRS has to be an idiojunctional escape, and broad QRS has to be idioventricular.
Actually, sir, it is very important for them to understand that in this thing, CCTGA, the penetrating bundle of his is very prolonged. And it's actually at the bundle of his that the complete heart block takes place. So Hisian escape is seen most of the times. Now,
Correct.
whenever there is a Hisian escape, it will conduct
Correct.
equally to the right ventricle and the left ventricle and involve the left anterofascicle and posterior fascicle. That's why you get very narrow, QRSs.
QRS.
And it's the same. If you have seen neonatal CHBs, again, the site of conduction it's always at the his. And of course, there is
Correct.
super fast conduction in neonates. So in fact, you can get very razor sharp QRSs in neonatal ECGs. So
Many
you
times
if
it
you
will be
understand,
2 to 1 block to begin with.
yes.
Okay, that's an important point. So anything else you would like to highlight in this ECG, especially after listening to Dr. Dheeraj Kumar telling that, the complexes are conducted through the normal narrow QRs. Anything you want to tell about the septal activation? You are telling
Yes,
about
sir.
some D loop, L
Yes,
loop
sir.
and all in your initial presentation. So how do
So
you
there is,
decide whether it is D loop or L loop? Dr. Pooja?
yes, sir. Yes, sir. So there is absence of Q wave in a lateral leads, which shows that there's a reversal of a septal
No, but
polarization.
you look at that V6, don't you think there was a small initial Q there in the narrow complex? And in V1, there was an initial R
Okay,
wave?
which is important,
Yes.
a Q wave in V1 or absent Q wave in V5, V6 or
No, I
septal
think
forces?
looking at the usage, it is not very easy to say it is an L loop because whatever you have shown is showing an initial small Q in V6, even for the narrow QRS. We agree that there's an inferior Q wave, that point is there.
What about the axis and the loop?
Um, so it is a left axis deviation, and it is situs solitus since P waves in one avial were upright and it was
No,
like,
situs solitus, we have no confusion.
yes.
We are trying to find out whether it's a D
Ventricular.
loop or L loop, which I think is not very easy. Anyway, it doesn't look like an L loop from the ECG. That's my point.
Okay.
Remember, inversion of the septal vector is one of the most important signs in the ECG, without which the diagnosis of CCTGA cannot be made from the ECG, I'm saying. So you'll have to look for the absent Q waves in V5, V6 and a QR in V1. Okay.
See, finally, it may be a character transposition. That's a different thing, but
Yeah, and also the septal orientation changes when there is a left-sided AV valve leakage in later years. So you may not get the classic VQ
Classical.
wave in V1, V2,
Agreed,
V3.
agreed.
That may shift to AVR. So
Correct.
that's why it's a little difficult. And you must understand, if you understand ECGs as a spatial vector, you will be able to explain in most of the cases what is happening in this. You are very well sure about the diagnosis by now. Then you have to fit the ECG to your diagnosis. You can think about what could be the possible explanations.
All right. X-ray.
So this is a well-exposed, well-centered PA view of the X-ray. It shows normal, it shows a cardiac silhouette and normal pulmonary areas. There is presence of upturn apex, and there is a left-sided aortic arch.
how do you decide whether the aortic arch is right-sided or left-sided?
So we will look for an indentation on a bronchus. If there is an indentation on the
Yes,
left
correct.
bronchus,
Correct.
it says it is
Here
Correct.
you can
left-sided.
Yes.
see it's a left-sided
Yes.
aortic arch.
The
Agree.
bronchus, which is more important, not the trachea. Okay.
Okay. Any peculiar contour for the left side? Cardiac silhouette?
It is an upturn apex, hump-like appearance, they say. But it is.
Do you think the left is above its formed by aorta, ascending aorta?
Are you able to see the ascending aorta? Even the aortic knuckle is not very
This portion.
conspicuous. You can see the descending aorta parallel to the spine, but
Hmm.
overall, the vascular pedicle looks very narrow.
Uh, Fine.
Moving towards transthoracic echocardiogram, there was situs solutus. This was a plaques view. Plaques view showed that we did not get an aortic valve and the LVO2, which we see in a plaques view. After putting a color, we see that there is a severe AV valve, left-sided AV valve regurgitation. On a four-chamber view, we saw that the valve which is present on the right side is proximally, whereas valve which is seen on the left side is distally, or it is apically placed attaching to the IVS. Then the ventricle, there was a coarse trabeculation of a left-sided ventricle, and there's a severe AV valve regurgitation.
See one point,
This
Dr.
was
Puja, look at the direction of that MR. Look at the direction of MR.
Going
That
towards
MR
the
is
Septal.
directed towards the
Septum.
interatrial septum, towards the aortic
septum.
root. That is why you are hearing the murmur towards the right stem
and
border.
the
That's
separation
evident
of
in
the
parasternal.
AML and I mean the left-sided and the right side is also important, no? Because you can have an Epstein's malformation of
Yes,
the
sir. Yes,
left-sided.
sir.
So, but here it's doesn't look.
So it's a loop which shows that the left-sided chamber, this is the left-sided chamber which is giving origin
Hmm.
this structure, and this is the right-sided chamber which is giving origin to this structure. I have highlighted it with the color in the next view. So this is the right-sided chamber which is giving origin to a structure which is dividing, which is likely the MPA, and this is
Okay.
the left-sided structure which is giving origin to the aorta. This was a Sachs view. It shows crescent-shaped RV and the LV, which is ovoid. This was the dimension. This was the great arteries relation, where aorta was placed anteriorly and the left side, and the pulmonaries are placed posteriorly and towards the right side. Yeah.
Right.
So the final diagnosis is situs solutus with leocardia, acyanotic congenital heart disease with RV type of apex with L looping of ventricle with normal pulmonary blood flow. A case of CCTGA with left-sided AV valve regurgitation with mild subsystemic ventricular dysfunction with AV dissociation without any signs of infective endocarditis, currently in INVICHA class 3.
Okay.
Is there pulmonary
Right.
arterial hypertension in this patient?
No, sir.
You saw a little bit of a pulmonary
It
regurgitation
was
jet
mild
in that
this in
echo
yes, sir.
because you have mitral regurg, you have got left-sided AV valve regurg. That could also account for pulmonary arterial hypertension.
Okay, sir.
Little bit is there, but of course, good color Doppler machines will show pulmonary regurgitations. So,
How can you get an idea about the pulmonary artery pressure from the pulmonary regurgitation jet?
Pulmonary artery pressure.
From
So
the
from
PR
pulmonary
jet?
regurgitation, we can get to know the pulmonary artery diastolic pressure.
okay.
Any other point?
From the right-sided AV valve regurgitation, if it is there, we can get to know about the pulmonary artery systolic pressure. Accordingly, we can calculate the mean pulmonary pressure.
Okay. Fine. Okay. So how do you proceed? Do you manage Before that, one question. How do you evaluate the His bundle in corrected transposition? If you want a His bundle electrogram, can you get the His bundle recording in the same position, or you may have to do something to get the His bundle?
So the AV node in this patient is placed more anteriorly and towards the right atrial appendage. So we may have to do some maneuver for getting his bundle electrode.
You can get it from the femoral vein puncture and right side, or you like to go from the left side. So one of the methods to take a His bundle is you go from the left side, hitch the catheter against the non-coronary cusp, and there you can get the His bundle recording. That is one of the methods to diagnose, to record His bundle in correct transposition. Okay, fine.
So, what will you do for this patient?
So we had asked for an intracardiac repair for this patient with the epicardial pacemaker insertion.
Supposing there is no intracardiac repair, can you still give a pacemaker? Can you give a usual pacemaker in corrected transposition?
Patient has presented with CHB.
So you can give.
Okay.
Can you put this into the morphological left ventricle, the lead? Not sure.
Sir is asking about which type of lead we can put. Active fixation, or we can put only tine lead.
What is the main difference between LV and RV regarding
Trabeculation,
the
RV is coarsely trabeculated.
LV is finely trabeculated. So unless you have an active fixation, the tines may not hold to the trabecle.
It may hold on.
In fact, it is said that you should not cross the right-sided AV valve and screw anything into the left morphological
Morphological
RV,
left
which is
ventricle.
yes, because what happens is it's exposed to systemic circulation, so embolic risk is very high. So you can put one of the leads in the right atrium, and the other lead you can access the coronary sinus, or you can pace, or you can go into one of the Tibetan veins in CCTG. So,
That's you understood, no? It's a very good point.
in fact, you can do his bundle pacing as well, because the intra-atrial portion of his is quite
portion
long.
is normal, yeah.
Yeah, but only thing is you'll have to trace his bundle where it is using the EP catheters so that you know exactly where to place your lead. Or again, you can use a pigtail in the aorta, which Majan sir says, because that's very important again as a marker. Just below that, you can place in the atrial part. Yes. You get decent capture.
Well, on the same topic, if you are not able to cannulate the coronary sinus, but you want LA potentials, where will you get it from? It's practical difficulties that it's not. It's you have never failed to cannulate coronary sinus, but still, in case you fail, you want to get the LA potentials. Where will you get that from?
Better the communications between RA and LA.
Isn't it? Okay. You can get it. You can take the catheter into the right pulmonary artery. It courses superiorly over the LA, and from there you can record the LA potentials. Okay. Right. Okay, that's. Want to summarize? I think it was a good presentation, and of course, you have to fit in the. You have to fit the what you call the clinical science and derive and give a good differential diagnosis, and then come to the conclusion, and not keep the corrected transposition in mind, although historically, yes, it is likely to be one of the strong differential diagnosis. So that is but it was done well, and you did very well for that. Sir, Dr.
Yes,
Koshi.
she presented well, but only point is you should have a diagnosis after the history, after the clinical examination, and after the ECG and X-ray, and then go to the echo. That's all.
Yes, sir.
You
Yes.
presented well.
Yes. Thank you, sir.
Dr. Pooja and the student panel and the examiners for the excellent case discussion. Pooja, you can stop sharing your slide, and now I request Dr. Dheeraj Kumar sir to uh, take on the OSCE, and request all the attendees to be ready for the OSCE.
Thank you, Arun sir. At the outset, I would like to thank the entire team of Heart Failure Society and Dr. Ajay Mahajan sir for having afforded me the opportunity to present this OSCE. Now, before we go into the OSCE, this is a basic level quiz, but what is important is I will add some clinically interesting nuggets to the answers. All you have to do is you have to show presence of mind and you have to use good reflexes, because this is based on fastest finger for max, to get a chance to answer. Read the questions carefully. There will be 60-second timer for each question. Please ensure to answer before the time runs out. There are no negative marks. Make sure that you have good internet connectivity. Make sure you don't receive any calls. And for optimal, answering of the quiz, you can open the quiz in your laptop and answer it using your mobile phone. Of course, the Menti app is useful. You can, scan the QR code. All right. Enter your full name as the registered name to receive the prize. Okay. With that, we shall begin the quiz.
Please remember that you should be answering on the interactive app and not on the Zoom chat box.
So we will begin with one just sample question so that you can get your answering right. That is not going to be marked. All right. Can you go to the next slide? So can you identify the gentleman onto your left, a very prominent physician and cardiologist of the yesteryears? Okay, fine. At least most of you could get your answers in. Does anybody want to hazard a guess as to who he is? All right, it's Sir William Musler. Can we move on? So the serious part of the quiz starts now. Again, a lot of the questions have to be have a lot to do with the past and emergence of cardiology as a field, because we must not forget that we stand tall on the shoulders of giants, as was stated by Sir Isaac Newton. Can we move to the next slide, please? He performed the very first cardiac catheterization on himself. That itself is a big clue. Who is this pioneer? What is he known for? And in which year did he receive Nobel Prize? We go to the options. Oh, some people still got it wrong. All right. So Werner Forsman is the right answer. He was, no, please go back to that slide. Please go back to the slide. Right. Werner Forsman was used a Foley's catheter to catheterize himself. He told his nurse that I'm going to catheterize you only, but you prepare the, table, etc. While she was preparing, he catheterized himself and said, "You will not speak a word about this." Went to the X-ray room 2 floors above, X-rayed himself. He was banned from that institute, and about few years later, he received Nobel Prize with Dickinson and Richards in 1956 because he was the first person. He opened the doors for right heart catheterization. All right. So must not forget this enterprising man. Please move to the next question. All right. So the biopsy to the right confirms it's amyloid. I'm not going to ask you about apple green birefringence. I'm not going to ask you about extracellular eosinophilic deposits. Okay. And modern guidelines allow a non-biopsy diagnosis of ATTR's cardiac amyloidosis using bone scintigraphy and, of course, serum and urine studies. But one finding invalidates a pathway and mandates a biopsy. Which finding forces a biopsy-based rather than a scintigraphy-based diagnosis? Is it A, monoclonal protein on serum and urine immunofixation, or an abnormal serum-free light chain ratio? Or is it B, a grade 2 by 3 cardiac intake on technetium pyrophosphate scan? Is it C, which is an NT-proBNP elevation, or D, an LV wall thickness of more than 12 millimeters? Can we move to the next slide so that the options appear and you can answer them? Okay, the answer obviously is a monoclonal protein on serum and urine immunofixation, because this is a medical emergency. If you remember this, that if a patient is diagnosed, he has very high chances of progression. The 6 month survival is abysmal. However, if there's not significant damage, immediate biopsy must be done and treatment for the monoclonal gammopathy must be started. All right, some recent advances, acoramidis and vutrisiran have expanded our therapeutic armamentarium in ATTR amyloidosis. This is disease modifying beyond tafamidis. CRISPR gene editing is the new kid on the block. Remember, you need to know more about CRISPR gene editing because in new future, in 5 to 10 years, more and more diseases will be treated by this methodology. All right. And of course, FDA has, clinically withheld a few drugs because of fatal hepatic adverse effects. So there is obviously a scrutiny issue and safety issue with modern therapies. All right. Can we move on to the next question? Okay. You want an FDG PET CT to assess disease activity and guide immunosuppression. Which patient preparation protocol minimizes false positive physiological myocardial FDG uptake, allowing true granulomatous inflammation to be distinguished? Is it a high-fat, very low carbohydrate diet plus prolonged fasting before the scan? Or is it B, a standard diet with no fasting? Is it C, a 4-hour fast only? Or is it D, IV glucose load before the scan? Okay, most of you got this right, actually. It is a high-fat, very low carbohydrate diet plus prolonged fasting. Remember, the myocardium is extremely glucose hungry, and even a little bit of glucose pilferage in the diet can cause uptake and cause false positive disease detection. So we need to look at a very high fat, low carb diet. All right. And now, of course, we have quantitative PET metrics, which are being studied to guide immunosuppression tapering, identify steroid refractory disease. So basically, you can compare the last PET scan with the current PET scan. It's not just positive or negative, it's quantitative analysis and identify steroid refractory disease. Suppose you start steroids and the PET actually doesn't change or worsens, or there's more uptake, then of course you know that you need to change the therapy. Can we go to the next question? Oh, he is credited with the first left heart catheterization. Who is this pioneer and what is he known for? Is it A, Henry Zimmerman? Is it B, Jeffrey Hartzler? Is it C, Adrian Kantrowitz? Or is it D, Nico Gilles? Okay, a lot of you got it right. Henry Zimmerman did the popularize the left heart catheterization almost 2 decades after Forcefield had demonstrated that right heart catheterization was possible. Now, it's very interesting to note that this gentleman was followed by selective coronary angiography. So we'll talk about that later. Okay. Of course, we have refined left heart catheterization over subsequent decades, and in all your cath labs, every day, so many patients are undergoing left heart catheterization, all right? Both by retrograde arterial and transseptal approaches. Please go to the next slide. Okay, you confirm ATTR cardiomyopathy and consider a TTTR stabilizer. In a pivotal ATTR ACT trial, in which subset of patients was tafamidis's mortality benefit most apparent? Hint, it's something to do with its mechanism. A, class NYHA class 1 and 2, that's early stage of the disease. B, NYHA class 3, more advanced disease. C, benefit was identical regardless of the class. D, only in wild type, what do you call ATTR, did it work? Okay, again, this one most of you got correct. Well, it's class early disease because once a significant proportion of ATTR misfolded protein is deposited, at that point of time, nothing much can, be done. It only stabilizes unbound ATTR tetramers so that they don't get misfolded and get deposited. So theoretically, every time you get a patient with discordant LVH and ECG findings, this is the stage when you ideally consider him for therapy. By the time an ATTR diagnosis is made, it's sometimes too late. So diagnose them early so that they can be treated. Of course, there are more newer therapies which look at proteosomes, etc., which can even take care of the deposited ATTR, but they're still in the pipeline. All right. Right. He performed the first selective coronary arteriography, largely by accident. Who is this pioneer and what is he known for? Okay, again, most of you got it right. It's Mason Sones indeed. He was doing an aortogram and the catheter slipped into the right ventricle and a large amount of dye was injected. He was horrified. He felt that it's going to cause a ventricular fibrillation. However, there was a transient asystole. He asked the patient to cough and immediately the patient recovered. He went to the technician and said, Ura, I have done something remarkable. And of course, it was the beginning of the era of coronary angiograms, because after this, we started defining coronary anatomy, and then CABGs were possible. So yes, this was a wonderful moment. Can you please go to the next slide? Okay, this is a simple one. An AAV virus-based gene therapy for phacoplakin 2 related ARVC is now in early human trials. The edited gene is RPA601. What is the mechanism? Option A, AAV delivered functional PKP transgene restoring normal phacophilin 2 expression. B, CRISPR knockout of the mutant allele. C, RNA interference silencing the mutant transcript. D, a small molecule chaperone stabilizing misfolded phacophilin 2. The clue is in understanding how this PKP protein defect ARVC is present. At what stage? Again, most of you got it right. Again, it's very interesting. This phacophilin gene is generally a result of two hit hypotheses. In initial phases, one of the copies of the phacophilin gene works. And a second hit occurs in middle ages when there is an exertion, sympathetic overactivity, and or there's a viral infection where the second gene also gets affected. Now, what this virus does is it just integrates it, gets transfers the gene to cardiomyocyte, and that does not interfere with this myocyte genome at all. This gene starts functioning independently and starts producing the proper protein, and therefore decreases the disease progression. All right. So after this, those patients who were on immunomodulatory therapy, they can be discontinued. All right. And of course, it can take care of life-threatening genetic cardiomyopathy. It is one of the genetic mutations which mandates immediate ICDs. Please go ahead. This everybody can get. He performed the first percutaneous transfemoral coronary angioplasty. Who is this pioneer? What is he known for? Is it Alain Riviere? Is it Jeffrey Hartzler? Is it Andreas Grudzig? Is it Werner Forsman? Okay, I expected everybody to get this right. So I'm surprised that a few got it wrong as well. So interesting. He, along with his wife and a couple of friends from Polytechnic Institute, developed the percutaneous balloon on the kitchen table. Interestingly, the same year that he was making this balloon, his daughter was born. And his daughter Sonja calls him the balloon angioplasty as a twin. All right. And of course, you know that the patient that he took up was a 40-year-old gentleman who was a smoker, was turned down by the surgeons, and he did it. And the patient outlived him. Unfortunately, Andreas Grudzic died in a plane crash. He was, I think, the pilot of the plane in 1985. So didn't even live 10 years after his wonderful um, procedure that changed the face of cardiology forever, making it from a clinical branch to an interventional branch, transitioning the branch. And of course, we have had millions and millions of angioplasties done. Please go to the next question. All right. Beyond diuresis, the Impulse trial changed practice in ADHF. Which therapy did Impulse show could be safely initiated in hospital during an ADHF admission with benefit on a composite of death, heart failure events, and symptom score? A. Loop diuretics, B. SGLT2, C. ACE inhibitors, D. Non-selective beta blockers. Even if you get the answer right, there is a very interesting statistical method that was used in this trial. If you can get that as well, bonus points to you. Yes, indeed, it was SGLT2 inhibitors, and it showed a significant benefit in win ratio. So win ratio became a new method of evaluating heart failure therapies, in which they looked at first trial, they started making theoretical pairs between the intervention arm and the control arm. Mortality benefit, yes, no. If mortality wasn't there, then the next matched pair was looked for. What they looked for was heart failure hospitalization. If that wasn't different, they would look at KCCQ. So they would look at wins across the two groups in all these pairs of symptoms. So that's a very interesting way of analyzing, heart failure therapy. Of course, after that, SGLT became a standard of care in ADHF patients as a initiation within the hospital for ADHF patients. Please go to the next slide. This patient's pericardium is calcified, chronic fibrotic constriction, generally requiring pericardiectomy. But a subset of transient constrictive pericarditis with elevated inflammatory markers can resolve without surgery. What is the appropriate initial strategy in these subsets? A, an empirical trial of anti-inflammatory therapy, NSAID/colchicine/corticosteroids before committing to surgery. B, immediate pericardiectomy regardless of inflammatory markers. C, IL-1 blockade with no other therapy, and D, loop diuretics alone. Okay, that's correct. An empiric trial of anti-inflammatory therapy before committing to surgery, because a significant, so basically CP is a spectrum from inflamed pericardium, which becomes stiff. And that's what leads to all the physiologic pressure changes of CP. On the other end of the spectrum is fibrocalcific pericardium. And most patients lie somewhere in between. So sometimes it makes sense to go for an empiric trial of anti-inflammatory therapy, especially when inflammatory markers are elevated. And very interesting is IL-1 blockade, rilonacept is basically sequesterer of interleukin-1. It sequesters interleukin-1 and therefore has been touted as showing some benefit in inflamed pericarditis. But again, um, not much clinical application till more and more trials are out. Quick check at the leaderboard. We have Ani, Dr. Ani as the leader till now with 9,945 points. All right. Closely following him is Vidya PL. So Vidya PL has to do some work to catch up with Ani. Maybe she needs to hit the buzzer earlier. Right. We go on to the next question. Okay. This patient has a CTO and a viable myocardium on imaging. Okay. And he has LV dysfunction. The traditional teaching says revascularize. Okay. Because he has got a viable myocardium. According to revived BCIS, viability arm, did PCI plus optimal medical therapy improve the composite of death, heart failure hospitalization versus optimal medical therapy alone in severe ischemic LV dysfunction with viability? And here are your options. The answer is correct. PCIM did not lead to any significant difference between the two strategies. Well, it's interesting. Before this, the paradigm was viability, revascularization, LV recovery. But this trial changed our thought process. It showed that viability did not lead to decrease in heart failure, hospitalization, and death. However, you know, and it didn't, even subgroup analysis did not yield any benefit from PCI. Perhaps a little bit of symptom relief, yes, but no difference in hard endpoints. Taken together with Courage and Orbita, just looks at because Orbita looked at moderate to severe ischemia as well. Ischemia itself is equal to viability. There's not much benefit in PCI apart from acute coronary syndrome. Please go to the next slide. Working independently in Toulouse and Lausanne, these two operators performed the first coronary stent implantations in 1986. Who are these pioneers and what are they known for? Is it Jake Spule and Ulrich Sigwart? Are they Cannon and Rubin? Zimmerman and Sohns and Kantrowitz or Jills. Oh, most of you got it right. Jake Spurl and Ulrich Sigvart. Basically, the first stent that time was Wall Stent by Wallace Stand, who was a developer, and he wanted these two people to work on the stent. And of course, they continued to perform stenting as a part of trial. They did the in vitro studies also. They did stenting in animals also. Jake Spule was soft-spoken. Ulrich Sigvart was fluent in English, and he popularized the entire stenting conundrum. Jake Spule was better known for his direct stenting philosophy, which of course became more accepted in the primary PCI era a little later. Okay, we can go to the next question. Observe this LV angiogram. This patient develops cardiogenic shock from Takotsubo with dynamic LVOT obstruction on echo. Why is inotropic support generally avoided here? Okay, almost all of you got it right. Catecholamines itself in excess are the pathophysiologic driver. More importantly, if you give inotropes in this basal hypercontractile variant, you're going to cause significant LVOTO and worsen the hypotension. So mechanical support is often preferred in Takotsubo-related cardiogenic shock, especially when LVOTO is preferred. IIT is also relatively contraindicated. Can we go to the next question, please? He pioneered primary PTCA using balloon angioplasty as the first-line treatment for acute MI, rather controversial circumstances. Who is this pioneer and what is he known for? Is it A, Adrian Kantrowitz, B, Mason Sohns, C, Alain Cribier, or D, Jeffrey Hartzler? Oh, there's a lot of confusion here. All right. It's D. Jeffrey Hartzler. Actually, he was working in Mid-American Hospital, and in 1980s, late 1980s, 88, 89, thrombolysis was the way to treat STEMI. However, he had this philosophy that thrombolysis is unreliable. Let me take this patient onto the table, and carry out mechanical reperfusion. Now, this was controversial at the time because there were no antiplatelets that were invented, and in STEMI you were giving all the blood thinners, etc. And warfarin. So there was a lot of post-procedure bleeding. It took 2 decades for his strategy to become, established as the way to treat acute coronary syndrome STEMI patients. And that I think was particularly after the 2000 year 2000 meta-analysis, which compared primary PTCA versus thrombolysis as a strategy. Please let us go on to the next slide. Cardiac myosin inhibitors, mavacamten and newer drug aficamten, were FDA approved in December 2025, are now the first line add-on therapy for obstructive HCM. What is the mechanism of reducing LVOT gradient? You shouldn't need options for this. Okay, the first question everybody got right. Think of actin as an oarsman and multiple oarsmen, and myosin as the river. So the interaction of active oarsmen with myosin helps in sliding the cardiac myocytes and leads to hypercontractility in HCM. Now it's interesting that this drug causes reversible inhibition of myosin, and which leads to decreased interaction between actin and myosin, and that leads to negative inotropy. Now, extending this mechanism, some people can have excessive negative inotropy, and they can go into LV dysfunction. Now, the difference is mavacamten has got a very long half-life. So it takes about 6 weeks to titrate and reach a stable dose. And once LV function goes down, it takes the same amount of time for the dose to reduce. The newer drug aficamten has got better pharmacokinetic principles. An interesting red flag is Southeast Asians have got more LV dysfunction as compared to the Western cohort with mavacamten. Okay, we go on to the next slide. Right. You want to quantify the apical sparing pattern rather than eyeball it. Which index has been proposed to objectively flag relative apical sparing suggestive of amyloidosis? Is it A, relative apical longitudinal strain ratio divided by average basal to mid strain with higher values favoring amyloid, or is it B, GLS alone, any value below 20, minus 20? Is it mitral E by A ratio of more than 2 alone, or is it deceleration time of more than 240 milliseconds alone? Yeah, most of you got it right. It is the ratio between the apical GLS versus basal GLS. Any value over 2.1 is supposed to be abnormal, and more than 4 is highly suggestive and specific for amyloidosis. Please go ahead. Fully implantable driveline-free LVADs. Avoiding the number one LVAD complication, that is driveline injection, are an active area of infection, are an active area of research. Which approach is being investigated to eliminate percutaneous driveline altogether? Is it transcutaneous energy transfer systems with a fully internalized power source or battery? Is it simply using a thicker driveline? Is it larger external battery packs? Or is it switching all patients to biventricular pacing instead of LVAD? Can we see the options? That is absolutely correct. Basically, infections are the Achilles heel of LVAD implantation. So there's a lot of research going to coil-based induction so that the entire battery inside can be charged and eliminating the need of driveline altogether. It still remains investigational and an early stage, but then that will help in transitioning patients into using LVADs as destination therapy completely. Can we go to the next question? Assuming this MRI shows amyloid pattern on LGE, T1 mapping is now used for earlier non-contrast detection. Which T1 mapping finding is characteristic of cardiac amyloidosis even before overt late gadolinium enhancement develops? Is it reduced native T1? Is it markedly elevated native T1 and expanded extracellular volume? Is it C, normal extracellular volume with elevated T2 only? Or is it D, T1 mapping has no role in amyloid disease at all? Okay. Remember that in amyloidosis, often patients have renal dysfunction. You can't use gadolinium for nephrogenic the systemic fibrosis. Therefore, looking at T1 images, uh, it's very useful. Not only that, remember that amyloid is an extracellular deposition. So therefore, extracellular volume expansion, is one of the earlier signs of amyloidosis developing. All right. Let's go to the next slide. Right. Desmoplakin cardiomyopathy is now recognized as a distinct ARVD with specific MRI signature, which LGE pattern is recently described hallmark, useful for arrhythmogenic risk stratification, even in patients with preserved LVEF. Is it a transmural LGE in a single coronary territory? Is it a diffuse subendocardial LGE enhancement? Is it a ring-like circumferential subepicardial or mid-wall LGE enhancement? Or no LGE is typically seen? Remember, desmoplakin is a glue which holds together myocytes, but also not only myocytes, but the skin cells as well as hair. So basically, whenever desmoplakin is abnormal, you can get woolly hair and palmoplantar keratosis. In fact, that occurs much before the cardiomyopathy develops, so offering a clinical window to diagnose before the patient develops a disease. The right answer is obviously ring-like subepicardial mid-wall LGE. So again, this is very interesting. It's again, if the LGE deposition is beyond the threshold which is being debated, it might be a indication to put an PICD in these subset of patients. We are trying to go beyond LVEF as a determinant of which patients will benefit from ICDs. Can we move to the next question, please? You need to distinguish this from restrictive cardiomyopathy on echo. Which tissue Doppler finding favors constrictive pericarditis over restrictive cardiomyopathy? Is it A, medial E dash velocity greater than lateral E dash velocity? Is it B, uniformly reduced E dash velocity at both medial and lateral annuli? Is it C, E by E dash more than 15 alone? Or is it D, reduced pulmonary vein systolic filling alone? Okay, it's medial E dash velocity, which is greater than lateral E dash velocity because the lateral wall is tethered by the stiff pericardium. Interestingly, it is one of the triads of ECG echo parameters, which has the highest sensitivity and specificity as per the second Mayo Clinic case series in diagnosing CP. The other one is annulus paradoxus, which looks at the E by E dash relationship with pulmonary artery pressures and pulmonary capillary wedge pressures. Well, that has been refuted in larger studies. Therefore, this annulus reversus remains a very, very precious clue in diagnosing patients with constrictive pericarditis. Please go to the next question. Okay, so we have come to the end, and now let us look at the leaderboard. So the winner is Annie with 19,823 points. Congratulations, Annie.
Congratulations, Annie. Uh, uh, or Will you please get in touch with them and identify the full name of the candidate? Congratulations, and the winner will be given an Amazon gift voucher and a complimentary access registration to the Heart Failure Association of India National Conference, Thiruvananthapuram 2027. So congratulations. Thank you, Dr. Dheeraj.
We request Dr.
Thank you,
Ani
sir.
to put his mobile number and email ID in the chat box.
Yeah, please, Annie, please request you to put your full name and your mobile number in the chat box so that we can pass on the voucher and the award. So thank you, Dr. Dheeraj Kumar. So it's a fabulous quiz, and we had very good interactive session. Also, we had images, we had clinics, and we had advances in echo and all. So it was fabulous. We had a wonderful session. I think I should thank everyone, starting from Saurabh sir's excellent talk on second heart sound. And then we had a great case discussion. Thanks to the examiners, Barendra sir, Koshi sir, Ajay Mahajan sir, Sundarsha sir could not join today. But the case presentation was done well by Dr. Pooja, and it was the learning keeps on going. And thank you, the student panel, Dr. Rajesh, Dr. Vinil, and Dr. Harsha, and Dr. Dheeraj Kumar for the excellent OSCE. And I should thank the entire team behind this heart failure clinics and masterclass, Chopra sir, Ibrahim sir, Harishan sir, Venugopal sir, Dr. Sajan, uh, the background staff from Heart Failure Association of India, Sumita, Hallmark team, Vinay, Coronas, Sun Pharma, and our collaborators from across the globe. So thank you for joining us and staying with us till the end of the session. We'll be back next month on the second Saturday for the next edition. Thank you all and good night.
Thanks, sir. Good night.